You're live, Chair.
Good evening and welcome to this Overview and Scrutiny Committee meeting on Tuesday the 5th of March. My name is Councillor Simon Morgan and I am the Chairperson of this committee. Members, we are streaming this meeting live as well as recording, and by being present in the meeting you are giving your consent to being recorded. During each item, please put your hand up to indicate if you wish to speak. I will then invite you at the appropriate time. Could I ask members to avoid approaching the top table, as this could create interference with the cameras and the live stream. Please note that the YouTube live stream sound recording is dependent upon the correct use of the microphones. Therefore, can I ask that when invited to speak, you remember to turn on your microphone and turn it off when finished. Please reference a page or paragraph number when referring to the agenda papers and keep your contributions as clear and concise as possible. So, moving on, agenda item 2. May I have any apologies for absence, please?
Good evening, Chair. We have an apology from absence from Councillor Whiffen, and as a substitute in her place, we have Councillor Thompson. Thank you, Chair.
Thank you. Moving on, agenda item 3, minutes of the last meeting. It is recommended that the minutes of the meeting held on the 7th of December 2023, found on pages 5 to 10, are approved as a true and accurate record. I so move. Do I have a seconder? Thank you, Councillor Neal. Can we pass that by acclamation? Yes? You agree? Good. Thank you. Moving on, item 4, declarations of interest. To disclose the existence and nature of any disclosable pecuniary interests, other registrable interests and non-registrable interests relating to items of business on the agenda, having regard to paragraph 9 and appendix B of the Code of Conduct for members. Members are reminded that they are also required to disclose any such interest as soon as they become aware, should the need arise through the meeting. Have any declarations of interest? No. Okay, moving on. Identified by public participation. I don't believe we've had any applications for public participation. Is that right, Sean?
No public participation. Public participation request. There we go.
Yeah. Okay. Well done. Got there in the end. Right. And welcome, members. Can I particularly welcome to Councillor Thompson, who's come here to substitute for Councillor Whiffen, and Councillor Driver. Good to see you here. Thank you. Right, so moving on to agenda item 6, the Mid and South Essex NHS. We have a verbal report and very pleased to welcome Mr. Doherty. So over to you.
Thank you. So I've got a number of things to cover for you, and I'll go through each item, and then I suggest, if it's okay with you guys, what I'll do is I'll pause at the natural kind of breaks when we move from one subject to the other, and then take questions on that particular bit before moving on. Obviously, I've seen an awful lot of some of you recently because of the consultation. I'm trying not to focus just on the consultation here. Obviously, I will touch on it, but I'm trying to give a bit more of an overview of other elements of service provision so that you can see some of the other stuff that's happening. The only other thing I was apologise for is Debbie, our head of midwifery, wanted to come to answer some questions on midwifery. She couldn't make it tonight. She's happy to come to a future meeting or to meet with people directly. Now, I'm looking at the slides on my screen, but this screen isn't connected to that screen, so I'm going to try and do this. So we thought we'd start with a summary of a little bit about primary care, and appreciating you won't be able to read all of this, but I'll summarise it for me. So what I'm going to talk you through is some data relating to primary care workforce roles, the number of contacts, patient ratios, patient to GP ratios, those sorts of things. They come from national reporting systems, trainee reporting systems, and other kind of primary care systems that we have. They are primarily focused on GP surgeries. Since April of last year, the Integrated Care Board that I work for also took on responsibility for dentistry, optometry and pharmacy. You'll often hear to us refer to it as POD, so pharmacy, optometry and dentistry. I haven't got data on pharmacy, optometry and dentistry in here. In time, I think that would be quite interesting for you guys to see, because it obviously is a very significant aspect of people's primary health care. I think it's fair to say my organisation is still getting to grips with being the kind of overseeing commissioning organisation for those services. But if I move on, the first, I say move on, I've got to click this one. The first slide that is showing you is the changes in primary care workforce between, this is covering the Maldon district, between this time last year and this year. So in essence, February 2023 through to February 2024. Broadly speaking, despite there being some increases in that data, what this shows is that there hasn't been a dramatic change in any of the primary care workforce. The two that are probably most interesting to you are the first two columns, which are GPs and nurses, and essentially show that we've got slightly more GPs now in the district than what we did this time last year, and we've got slightly more nurses in the district than what we had this time last year. It really is only slightly though, because that first number, you probably can't quite see it up there, but it's 47.9 and it's now 50.9. So in essence, we've got one extra GP, and according to those numbers there, we've got 3 extra nurses. The other numbers are where it says direct patient care. There are other professionals involved in primary care contacts, and I'll come on to some of those in a minute. The final column is admin or non-clinical, so that's obviously the sort of back office staff, receptionists, front of house staff, managerial staff, those sorts of things, and there's a subtle drop in the numbers of those, but again, it's not particularly significant. What is a little bit more significant, if I flick on, is that we've seen some changes in the makeup of our GPs. The first column is what we call salaried GPs. So these are non-partner GPs. They don't have a they're not partner members of the business. And remember, GPs are sovereign businesses, they're independent businesses, they're not part of the NHS as a whole, which a lot of people think. And one of the things that we've seen, and it's a national trend, is that a lot of GPs, particularly younger GPs, prefer to work now as what are called salaried GPs than GP partners. GP partners often have inherent responsibility for their building. They might often own their building, but they also have all the employment kind of liabilities for running the business as well. Salaried GPs are more like an employed member of the workforce. So they have set hours, they have a set salary, and they have terms and conditions that relate to that. Many younger GPs prefer the salaried route because they can go home at a set time and they're not obliged to do any of the other stuff. They're not responsible for the upkeep of the building or the business or any of the liabilities that sometimes come with those businesses that historically GPs have had. That said, within the Maldon district, and this is contrary to the national trend and contrary to our local trend, we have also seen an increase in the number of partners and the number of senior partners within our district. So you can see senior partners there blue to orange and partners there blue to orange. We've actually got more partner GPs than what we've got than what we had this time last year. That is against the national trend. So that's an unusual trend for this district. The only caveat I'd put around that, typically I would claim that as good news. The only caveat around it is there are relatively small numbers within the Maldon district, and if you look at some of the ratios, which we'll come on to in a moment, it's apparent that the Maldon district has struggled to attract doctors for some years, and so whilst that shows an improving trend on last year, it's something that we need to continue to work on to encourage, because we want to attract partner GPs particularly, and salary GPs for that matter, into our district. The final one that was a bit of a concern to me, which I asked about, is we've actually seen a drop, if you can see at the bottom, of GP trainees, the blue to orange. So this is where our practices become host practices to train new GPs coming through. That's bolstered somewhat by the fact that we've now got a medical school that focuses on primary care at Anglia Ruskin. That is a concern, and it's something that we're trying to address by increasing what we call educator capacity across the practices within the Maldon district. But it is one of our challenges, and we'll touch on this later in the presentation, whereby some of our practices now struggle to meet the requirements of becoming education-based or training practices, as they're known, because they're limited in space, and there are quite strict requirements on how much supervision trainee GPs need. Now, I'm not speaking on behalf of all the practices, but what some practices are telling me is when you're obviously struggling to meet the daily demand, using some of your capacity, both in terms of space, but also the GPs that you have available to teach younger GPs, whilst it can be beneficial, it can also detract from meeting the workload coming in. The problem with it is obviously many of those trainee GPs, if they have good experiences in practice, are the ones that then go on to become the salaried GPs or the partners that stay in our district and serve the population. So bolstering that number is something that we'll certainly be focusing on as an organisation, but it is something that in partnerships with yourselves that we work on, because we want to make our district an attractive place to come and work. This is GP to patient ratio, and this is in essence what I was referencing earlier. So what you can see there is that nationally, you would typically get around about 1,700 patients for every full-time equivalent GP within a patch. Within the Mid and South Essex Integrated Care Board, which is the area that I work for, so Maldon, Braintree, Chelmsford, Basildon, Brentwood, Southend, Castle Point and Rochford, that ratio is higher than the national average. It's around about 2,000. So each GP has on average typically 2,000 patients to look after on their list. In the Maldon district practices, it's higher still, and it's at 2,256. And that's back to my point that whilst we've seen a growth in doctors in the Maldon district, we need to continue that, because ideally we want that ratio to be round about the 2,000 level, which would be the ICB average. We struggle typically in Mid and South Essex, more so in our coastal and rural areas, of which clearly the Maldon district has both coastal and rural areas, and they are some of the most difficult areas to recruit. We've done a lot of work in recent years, particularly in the Dengie, in some of the practices in the Dengie, trying to attract GP partners or salaried GPs into the Dengie, but it is a challenge. If I look at just my patch, somewhere like Central Chelmsford finds it considerably easier to encourage GPs to come into partnership or as salary GPs in Central Chelmsford, and the ratios are lower in Central Chelmsford than they are somewhere in the Maldon district. So something that we need to be aware of, and that caveats that first slide that I showed you that shows that despite having increased GPs, it would still be great if we could get more GPs. Many of our practices are still trying to get partners, and just recently, if any of you are Blackwater members, you'll have seen in their newsletter that came out just recently, they've recently recruited a new partner. Getting a new partner into a practice in Maldon is a real success, actually, because it's been historically quite difficult. Just flicking on, the next slide, and you'll have to forgive, obviously, the NHS, we love 3- and 4-letter acronyms all over the place, but You'll hear people in the NHS refer to ARS roles, ARRS. It stands for Additional Roles Reimbursement Scheme. In essence, what this is this is a national initiative to encourage non-GPs and non-nurses into primary care, into general practice. And I'll show you the professions that it's focused on in a moment. But what that right-hand graph shows you is that the additional roles that are covering the Maldon district, you can see, have grown pretty steadily now since they were introduced in 2020-21. So we had 24 in 2021, we had 50 the following year, we had 62 the following year, and we're up to now 92 in the district. So in the last, 4 years, 3.5, 4 years, we've now got almost 100 additional members of clinical staff in primary care. When you look at the makeup of those staff, you'll see it on this slide. So over a quarter of the staff, 26, are clinical pharmacists. The GPs love having the clinical pharmacists in-house. They can do structured medication reviews. They can look at people on multiple medications. They can streamline prescriptions. They can do a lot of the workload that would typically and historically have fallen to the GP. Other ones that I would say that you'll see a lot of in there are things like care coordinators and social prescribing link workers. What that demonstrates is the fact that a lot of the workload that is now coming into general practice is not necessarily of a clinical nature. GPs will tell you that they're seeing an awful lot of social non-clinical problems, things to do with housing or employment or the ability to work or something like that. Those sorts of things come in, and quite often they can be dealt with by someone that's trained in social prescribing. Often it's about creating a network around an individual, but not necessarily giving a clinical treatment or a prescription. Other things that you'll see in there are things like what are called first contact physiotherapists. I'm a physiotherapist by trade. The idea here is that if you're going in to see, let's say you strain your back and you know, you've given it a bit of time, it's not clearing up. Often people who've got the means themselves will simply go and see the chiropractor or the physiotherapist and pay to do so. The general public, historically, if they haven't been able to afford that, go to a GP. They wait to see the GP. The GP says you need to see the physio and refers you on. Now you have a physio straight in-house and you can be directed straight towards the physio. And it goes on. There's other things in there, including things like paramedics, who often will do home visits on behalf of the GPs, mental health practitioners, and so on and so forth. The key thing here, and the important thing, I suppose, for you guys with your constituents, is to understand this is increasingly now why GPs are asking people what the problem is prior to consultations being given. Because if a patient reveals that it's, using my example, a back pain that's not going away, quite often they can be booked directly in with the first contact physio, bypassing the need of getting a GP appointment. If it's for an asthma medication review, quite often they can be booked in with the pharmacy technician, again bypassing the need to go straight into a GP. So it's about trying to free up our GP capacity, but equally to get people in front of the right right clinical staff as quickly and as soon as possible. I'll pause, if it's all right with colleagues, I'll pause there because there's some other information, but are there any questions up until that point on any of that information?
Councillor Stevens.
Thank you, Mr. Doherty. It's really interesting. You gave us some finite figures and you gave us a ratio. So the finite figures showed an improvement over a number of years, which is tremendous, but the ratio is just sort of now. Is the ratio on its way up or is it still on its way down, please? Thank you.
The ratio tracks the finite figures. So the fact that we've got more GPs, you would immediately think that the ratio's improved. The caveat to that is we've got a bigger population as well. So you're correct that the ratios, broadly speaking, over the last 3 or 4 years, we're really looking post-pandemic, Councillor Stevens. Because our information since then is far more accurate since these systems were introduced. They didn't predate the pandemic, but also because of the changes in contact types within primary care and the introduction of the ARS roles. Within our district, the ratio has stayed broadly the same because we've seen a slight increase in the number of GPs, but we've also seen a slight increase in the population. So in order to bring that ratio down, because our population has increased in that time, that was back to my point that we need to try and get more GPs to improve that ratio. That said, if you look at, and this isn't nationally published data, but it's something that I've looked at occasionally, because of that increase in ARRS roles that we've just referred to, the ability of our GPs to be face-to-face with their patients, or non-face-to-face for that matter, has improved. So whilst the net volume of patients per GP has stayed broadly the same, the amount of time the GPs can devote to their patients has improved because we've got those 95 additional clinical staff in those other roles to take some of those patients. Hopefully that answers a good question though. So, sorry, do I have to press this off?
Yep. Actually, Dan, a question of mine. You say that it's very difficult to recruit GPs to Maldon. Can you give any particular reason as to why that is?
We've done lots of work on it over the last 10, 15 years. If I was to give you 2 or 3 things that come to the fore, one is the choice of schools. A lot of GPs will, particularly younger GPs, will look at where there are a wider variety of schools to choose from, particularly grammar schools or private schools. Transport links is significant, again, for younger GPs. And the other thing that's significant is the nature of practices. It's not universal by any means, but particularly young GP partners often like to be in big, what I would call strong, stable partnership practices, which are usually 6, 7, 8 plus partners serving big populations. Many of our practices, particularly those out in the rural communities like the Dengie, are much smaller partner practices, 1 or 2 partner practices. Historically, GPs would take that role for life. It's a contract for life in perpetuity, and it can be handed on. And we have instances in the Dengie of GP contracts going from father to daughter or so on and so forth. The concern that a lot of young GP partners have is becoming a partner on a 1 or 2 partner list, particularly with older partners those older partners retiring, and then the term they use is unfortunate, but last man standing, but they become the person that inherits the running of the business. So generally speaking, you'll see GPs going, as a rule, going to bigger practices, which tend to be in towns, bigger towns, cities, and so on and so forth. That's not universal, but they're two or three of the key things that are cited.
Okay, thanks. Any further questions? Councillor Driver.
Thank you, Mr. Doherty. It was very interesting. Can I just ask about this R's?
Yes.
I mean, you've presented there a significant increase over the last 3-4 years, but how does that compare nationally? Because is that significant just to our area, or actually is this something that's happening across the piece, or is it even better elsewhere than it is here?
You're right, it's a national programme, so it's a nationally funded programme, and the amount of resource that's given to GPs is proportional to the size of the populations that they serve. We are sort of, I guess, managed on ensuring that these roles are filled as best as we possibly can, and so broadly speaking, what we're seeing with our practices in the district is broadly in line with the rest of our patch and arguably the rest of the country. There are areas and certain professions where we're doing better than the national average, but there are other areas that we're maybe not doing so well. So some areas are seeing are using paramedics more, for example, whereas we're struggling and not just in Maldon, in Essex, South East in general, around paramedics. We're probably ahead of the curve in terms of clinical pharmacists, but broadly speaking, it's in line with average, and so it is consistent with, as you put it, across the piece, it's across the country that this is happening.
Councillor Spencer.
Oh, thank you, Dan. One statistic I haven't seen there is how we're faring in terms of access to GPs per head of population, and I do believe we're quite behind the national curve on that. I think it's about 17% more patients per GP than elsewhere nationally, but I could be wrong about that. Don't quote me, but I've seen that somewhere.
17% more.
In other words, the access to a GP is affected by us having so many people per GP.
That was the GP to patient ratio.
You've got. Oh, did I must have missed that. Can we go back to that? Because I'd like to know how it compares nationally.
I'm going to have to do a. Sorry. National.
Oh, right. I couldn't see the figure
GP.
from here. That's right. I couldn't see the
GP
writing.
I think
Okay.
for the minutes, I think I did read them out, so hopefully they're on there. So nationally, it's 1 to 1,700.
Right.
ICB, it's 1 to 2,000.
Right.
Maldon district is 1 to 2,250. So we are, I guess, we are an outlier in the ICB, and we are an outlier nationally. So
what's the? We haven't got sort of any kind of idea of how that's progressing from previous years. So
that's the question that Councillor Stevens asked.
Yeah. So it's
that broadly speaking, the ratio in the district is the same.
Yeah.
And that's because we've got slightly more GPs, but we've also got a slightly higher population. So we've kind of kept relatively steady.
Right.
But we've not
Sure.
closed the gap.
Sure, we've not closed the gap. Okay, and how would that compare? I'm sure you haven't got that data with, say, a point in time 5 years ago and 10 years ago.
So that was the point, again, that I said in response to Councillor Stevens. The national workforce data that we've got on this is really only valid sort of since the pandemic. We do have some national data, and generally speaking, up and down the country, GP to patient ratios have been deteriorating. Most GP, I don't know of anywhere nationally, Paula, that is actually bucking that trend at the moment, which is, generally speaking, there are now more patients per GP than what there have been historically. That ratio
so going back to the point that Councillor Stevens made about that, you're saying that you haven't really got reliable data from prior to the pandemic.
We do for GP, we do for GP to patient ratios based on what are called, it's basically the LMC, the GP's local committee, had estimates on it, which I'm sure I could get to you if you're interested.
I'd just be really interested to see, because it seems to me, we have a lot of information that seems to come from the pandemic, but nothing compared to what happened before in a lot of areas, not just with this data. I mean, and it'd just be really useful to see because in terms of this area has grown quite a lot in the last 10 years, hasn't it? And I think it'd just be really interesting to see that information and see how that's changed.
I'll see what I can find out.
For me, yeah, I'd just like to see that. Thank you.
Councillor Morley.
Yeah, thank you, Ms. Stockley, for coming. I have to say I didn't realise that about doctors going into practice or partners and those that didn't. You say about schools, are there any other incentives that are being bounded about? Can the risk be taken more with the NHS to help them? You say about the risk with running it, or on their shoulders, as it were. Thank you.
I mean, it's a good question. I'll be honest, we've tried lots of things. Many practices have tried like golden hellos and things like that to say, come to this practice. I mean, there's a GP in the Dengie, Dr. Hancock, if any of you know him, who even did a YouTube video of how wonderful it is to be on the Dengie. So people have tried lots of different things. We've had particular support in the Dengie actually within recent years to try to improve GP contact time, to try and I guess de-burden the role of the GP, to allow them to spend more time with the patients that they need to spend time with. Because one of the things that GPs find frustrating is obviously that they're having to do all things for all people, and often they're not able to give the time to those people they feel they need to. So that was a sort of a precursor, if you like, to the ARRS roles in terms of piloting that type of work on the Dengie. It is a real struggle. It is a genuine struggle, as I say. I think the big key for me is focusing on the trainees coming through, because if we can, this is true not just for GPs, it's throughout the NHS. If a trainee goes to an environment, a GP practice, and gets a really good experience and learns an awful lot, it's one of the biggest factors in determining that they would then say, I'd like to work there. So that does relate to some of the conversations we'll have in time, because the ability of GPs to give an excellent training experience within their practices does often relate to the amount of space and time that they then themselves have available to devote to trainees. But believe me when I say we do try lots of different things to try and attract them in. The reality is that there simply aren't enough GPs in the country to go around at the minute. So if you get them, they're like gold dust. You've got to grip them, which is why it's so great. Blackwater have just got a new partner. But if there are other ideas that you have, I'll have a conversation with you outside, and I'll happily explore them.
Yeah, thank you. It was just through you, Chair. Sorry. Wasn't necessarily financially. You were saying about the was not fear of prosecution, but are there worries more on a practice in a partnership rather than is it more of a burden on their shoulders? That's what I mean. Thank you.
100%. So a young GP I'm not saying this is necessarily happened in the Maldon district, but certainly in my time in my role, I've known GPs that have joined a practice with 2 or 3 partners. At the point that a younger GP's joined, the older partners take that at a point to exit, and then suddenly that younger GP finds themselves solely responsible for what is often a multi-million-pound business, sometimes responsible for a property that maybe has work and maintenance to be carried out, and it's a real burden that a lot of them don't want, based on when, as I was saying, when they take that salaried role, none of that is their responsibility, and when they finish work they go home and it's not their problem anymore. So that's why it is a challenge. It is a real challenge.
Sorry, Councillor Stevens.
Oh no! I was going to say I was going to say at some point I'll move on, because I've got some other GP information that may generate further questions or may answer some of the questions that are coming. But please go if you'd like to.
Thank you. Well, it was a question about is it Rs? Is that what you say, Rs? Yeah. So if you're a surgery of, say, 5 GPs and you have a trainee, maybe you could have the trainee with a different doctor each day and spread the load a bit, because it's great to bring other people in, but it is time consuming. But if you're a surgery with only 2 GPs, that doesn't really work so well. And I wonder, and not just for trainee GPs, but for any of these, how do small practices manage it? What support is there? So if I phoned my GP, I think even though they've only got 2 GPs, they do have a social prescriber who I think also works in other practices. But I don't know if that's just a relationship that these GPs have managed to forge, or is there some bigger help for little surgeries? Thank you.
Again, it's a very good question. The training one, individual GPs have to become certified as GP trainers. So in essence, you can't just put your hand up and say, and it's something that lots of GPs enjoy doing, but not all of them. You're absolutely right that a smaller practice may be less likely to do it, because they often have less space because they maybe have survived with just 2 partners for a long time, and exactly the point that you made, that it will always fall down to the same 1 or 2 individuals. That relates back to the previous councillor's question about how sometimes it's harder to recruit partners because they're less able to train. So they can't necessarily, I don't think that they can share that, but I'll double check that, Councillor Stevens, because I'm not 100% sure whether there's not a mechanism. If there isn't, it's a very good idea, so I'll mention it. The ARRS roles, you're absolutely right, they are shared across wider GP populations and networks, and so it's unfortunate because if this is where GPs cooperating together makes a big difference, because if you're a relatively small practice, let's say you're covering a network of 30,000 people, but your practice only has 2,000 registered patients, you kind of get an arm of a physiotherapist, but not if you do it that way. The idea is that practices work collaboratively and share resource across different areas. So if it is a social prescriber, they employ one that covers a population of say 30,000 people. They don't always then have to even be based in the surgeries themselves, and quite often, and we've got scenarios here in the Maldon district where they might base themselves, for example, they've done that occasionally will base themselves, I was pointing downstairs, but downstairs here, because you've done days where they can base themselves in here and those sorts of things. So the most successful, I think the GPs are working really cooperatively together. In fairness, I would say we still have some areas where it is a little bit more, practice A gets them for a day, practice B gets them for 2 days, practice C gets them for 2 days or something like that. I think most of that is moved on, but not everywhere, Councillor Stevens.
Councillor Siddle.
This situation hasn't changed. It was the same 30 years ago. We've always had trouble getting doctors. We've always had trouble getting teachers. And they're all for the same reasons as they are now. That they don't really think that they want to come out to the Dengie 100. Now, I have to say to you this. Who advertises for new doctors? Is it you, or is it the partners in a place?
It's the partners that advertise themselves, although they are supported by ourselves and their local medical committee, all of whom will take their adverts and put them on kind of nationally available websites and things. But it's ultimately the partnerships themselves that choose to recruit.
Thank you.
Right, Dan, do you want to continue?
Yeah. So if I move on, there's some other ones, and apologies because if I'd had more time, I would have slightly restructured this slide, and if I get the chance to send it out to you, I will. But this is a very interesting slide that I think many of you might want to digest later and also share and look at kind of your local your local kind of constituency. What this basically shows is the number of appointments within a particular, losing my own screen again, but within a particular practice related to the list size of that practice, giving you a number of appointments per 1,000 population. So this is how many GP appointments are offered per 1,000 of the registered population. What I would have done is order it from high to low, but it isn't. It's ordered in what's called our F codes, which is the codes that we use to analyse practices. But just to point out to you here, and you may well want to pick this up with me individually, what you can see is that actually a number of our Dengie practices really kind of stand out here in that they offer a very high volume of of contacts per 1,000 head. So the Burnham surgery at 654, William Fisher at 599, so say 600, and the Dengie Medical Partnership at 603. That's obviously Maidensea and Tillingham. Trinity's up there, almost approaching 600 in Maidensea. So what you can see is almost all of the Dengie practices are offering almost 600 patients on average per 1,000 patients that they have on their list. If you contrast that to, for example, the Beacon Health Group, which is in Danbury, it's offering 327 appointments per 1,000 people on its list, which is almost exactly half that of the Burnham surgery. Now, there's different reasons for that. Some of it, this is GP appointments, so some of it relates to the ratios that we've spoken about previously. Some of it relates to the availability of R's roles. Some of it relates to the historic nature of demand in different areas, which is not always, if I say it's not always related to need, sometimes historic provision stimulates a kind of, almost a kind of, a historic demand that continues, but you can see that it's vastly different actually, and we've got quite a spectrum there. Greenwood and Wincroft surgery is actually now based in the Chelmsford district, but Wincroft serves Bicknacre and does have part of the Maldon catchment. So there are some on here that you may not recognise. There sometimes you have surgeries that are in different districts, but they still have registered patients from the Maldon district. But key ones also for the town, Blackwater and Longfield. You can see Longfield's offering 523 appointments per 1,000 and Blackwater 474. So the only thing that I would caveat around this is there are nuances. So GP data is notoriously sort of volatile, and so what you would often find is if you go into some of these practices and you augment this GP list with some of those R's roles, you'll find that some of the ones that are maybe offering lower numbers of GP appointments per 1,000 are offering significantly more pharmacy and paramedic appointments. That to some extent, Councillor Stevens, relates to what you were saying about them being able to employ more whole-time equivalents because they're simply bigger. Now, you'll have your own opinions as to how relevant this is, but simply more GP appointments per 1,000 is not necessarily always a good thing. Some GPs would argue that if that ratio becomes too high, it actually limits the amount of time that an individual GP can spend with individuals, particularly in chronic conditions. Other GPs, though, would argue that it demonstrates continuity of care, particularly in a lot of those Dengie practices. They're often being offered by the same 2 or 3 GPs, which is why they often score very, very highly, our Dengie practices, on patient satisfaction surveys, because patients see their regular doctor week in, week out. Some of the ones with lower ratios, you might see different people every time you go, and obviously some patients don't like that. Again, so this is why it's quite nuanced, and you can't immediately jump on one and say it's good or one or say it's bad. But what it does demonstrate is we've got quite a significant spectrum. And if I will open to questions in a moment. If I then flip on to this is face to face, and again I've done a little bit more work on this slide since it was published to you. I haven't actually flicked that one on yet. Sorry. This basically shows the information that we have on how GPs are seeing their patients. Are they face to face? Are they home visits? Are they telephone consultations? Are they video or online, or are they unknown? GPs are only, I guess, in the last, again, and it is unfortunately, Councillor Spencer, since the pandemic that this information has started to be recorded. Historically, they haven't recorded this as accurately as what they do now. And it's fair to say some practices are still not accurately recording all of their consultations the correct way. What I've actually done, though, and apologies because I will make sure that I get this sent round, is I've looked at this as a percentage, because raw numbers is not particularly helpful. But to give you an example, based on the data that's submitted, and I'm going to just double check this one, but for example, William Fisher, so Southminster, is offering about 97% of its appointments face to face. So the vast majority of people, according to the submitted national data in Southminster, are going in and seeing somebody face to face. I suspect that they might be doing a bit more online than that, so I'm going to check with them about their coding. If you contrast that to one of the ones that's towards the lower end of the patch. Well, actually, the national average is 67%. So nationally, 67% of the GP contacts at the moment are face-to-face, with 33%, doing my percentages right in my head, being via some other means, either telephone or online or something else. So our ICB average, our Integrated Care Board, is 77% face-to-face. But if I say some of them out loud, Longfield is 68% face-to-face, Tollesbury is 83% face-to-face, Blackwater is 73%, Beacon, Danbury is 82%, Burnham 78%, William Fisher, I said 97%, the Dengies around 70%, and then Greenwood and Wincroft, that one towards Southwood and Ferries, is about 70%. Trinity, the one in Mayland, we don't have because their computer system doesn't record this information at the minute. But what that shows is that, broadly speaking, with the exception of just looking at it, actually all of our practices, from what I can see, Longfield at 68.3 are possibly the only one who is slightly... No, I was going to say slightly below the national average. Even they're ahead of the national average. So all our practices in the Maldon district are offering more face-to-face appointments than the national average. But then relate that back to the total volume of appointments in the previous slide, and you start to get interesting questions as to what's going on. I'll stop there because that's the end of what I was going to talk about for just primary care access information at this point. So the next bit, I was going to go on to some other primary care information. So if anyone's got any additional questions.
Yeah, I just noticed that there's a number of practices don't have any home visits or online facilities. Is that because there's an actual policy not to offer those facilities?
My sense is that will be a data error. If we go to those practices, they will home visit nursing homes and things like that. I suspect they're not recording those visits as the appropriate code. We do find that a lot. We often find that people who convert telephone appointments to, for example, virtual digital appointments, they don't do the conversion and things. So they are. So that's why I say if there's a particular concern about a particular practice, what we generally do is go and speak to that practice. And what we often find is they'll say, oh no, we do loads of those or something. So well, none of it's in your data, and it's because somebody's not coding it the right way within the practice.
Thanks.
So,
any other questions? Councillor Stevens.
Thank you. Sorry, could you just advise us which year that last
that was
graph?
current. That was the current. The year up,
Current
year to date. Yeah.
Okay. So I'm pretty sure there is some erroneous coding going on there.
There absolutely will be. Without a shadow of a doubt, there will be erroneous coding.
Thank you. And on the previous slide, you had the appointments data. Do you get that more adjusted for the age? So if you had a really, really young population, you might just have less demand. And if you have a much older population with 3 care homes, you'd get tremendously more demand. So is that data available modified? Thank you.
Yes and no. GPs have 2 list sizes. They have an actual list size, and then they have a sort of relative list size that's adjusted for some of the factors that you've referred to. So they call it their weighted list, basically. So a practice with no anomalies within the population for every 1,000 patients would have a weighted list of 1,000 patients. If a practice is determined to have a higher need, for every 1,000 patients, their weighted list might be 1,100, and that relates to the resource that they get given. So many of the practices on the Dengie will have a higher weighted list than what their actual list is. So they'll essentially be paid on the basis that they're looking after more patients than they actually are, because there's a national formula that determines that the needs of that population, and Councillor Stevens, if you want to spend a whole evening, Google it, because the formula is ever more complex. It's called the Cahill formula of funding, and it's ever more complex, but it does take into account deprivation, it takes into account age, and it takes into a number of other modifying factors that come from data on the population. A lot of GPs argue the Cahill formula is out of date because it doesn't necessarily take into account things like care homes, exactly as you said, and obviously if you're a relatively small practice, and I'm giving you, I won't say which practice I'm talking about, but there are practices like this on the Dengie that may have, 3,000 or 4,000 patients, but could have a couple of big care homes, that can significantly sway the demand on the way that you're saying. The only way we can do that analysis is by getting individual data analysts to do it manually. There's no sort of national thing that does it that way. The weighted list is the nearest to it, but I know that many of my GP colleagues would argue that doesn't accurately demonstrate the exact need that they're getting. The opposite end of the spectrum, though, for example, would be that GPs in Southwood and Ferrers, that serves parts of the Dengie, actually often come almost below their actual on the weighting, because Southwood and Ferrers is deemed to be affluent and healthy, but they would argue that the demands that they face are significant as well. So Carhill is if you want to get a GP going, speak to them about the Carhill formula.
Councillor Driver. Oh, well, right.
Sorry, just to come back on that. So it sounds like they're more detailed or the weighted statistics would be available, but if they're not available to a GP surgery, then they can't measure themselves. They've got nothing to benchmark themselves against. So it's not whether I can see that data, but can GPs see it?
Absolutely. All of the data that I've presented to you this evening is actually nationally available, and if you search online, you could have got everything that I've given you tonight, apart from the percentages that I read out, which I've got a member of my team to do. So since you'll remember that, I'm trying to think when it was probably 2 years ago now, there was a significant kind of increase in the national press around GP face-to-face ratios and various different things. Since a lot of that attention, the focus on GP data and the nature of GP data that's being recorded has increased significantly. Hence, some of the data that we've got now is somewhat more sophisticated than what we had years back, but it's all nationally available, Councillor Stephen.
Councillor Driver.
Thank you. The consultations per 1,000, I presume that's annual?
Well, yeah.
Yeah, wouldn't be per week, which would be... Thank you, just to clarify.
Oh, let me double check it, actually. You didn't say that.
Well, otherwise it doesn't. Sorry, otherwise it wouldn't. It has to be over a given period that you can compare. Otherwise, it doesn't mean anything.
Yeah, I suspect it's per month. Actually.
Per month.
Annually. Yeah. So
That would rather suggest then that if it's say 500 out of 1,000, then if it's per month, then of the 1,000 people, there would be per month half of them per month would be seen. Half of the population would be seen by a GP every month.
No, because what you find is that there'll be several people in that who get seen multiple times. Yeah. So, but in essence, yes. So if you look at the national data, what you see is that the primary care has almost tenfold volume of that which go to A&E. So it is almost, on paper, the way that you say it is correct. That isn't the case, though, because what you often find is that demand is actually derived by about 20% of the population, with the vast majority of that demand being derived by 2% of the population. So what you often, but I'll double check it, but I'm pretty certain that's what it is. So yeah, and so the volume of activity that is seen within primary care each day is vast in the NHS. When you compare, people often talk about hospitals and talk about A&E, that the volume, obviously the complexity and the acuity is higher, but the volume in primary care every day is absolutely huge. And then bear in mind what I said earlier, what we don't have yet in this data is the volume being served by dentists, optometrists and the pharmacists. When you add that in, there are huge volume, and I believe nationally it is more than half. If you take it as a pure stat, more than half of the population is seen each month, but clearly it isn't because of the demands of the higher needs. Yeah.
Okay. Do you want to press on? Yep,
Yeah.
please.
I'm gonna kind of whiz over these ones relatively quickly. That went backwards. This was just to say a number of people have mentioned in the Tollesbury area that they're having trouble being referred up to Colchester. There are parts of our patch, Tollesbury in particular, that often through choice would prefer to go to Colchester Hospital, and we know that there are a number of issues with not only referral pathways but also blood tests going to Ipswich labs rather than Broomfield labs. I just wanted you to be aware that I'm now aware of that, and I'm sort of investigating that and working with colleagues to try and address that. The other thing that I won't go into all of this, suffice to say that many of our practices now are working on what we call sort of cloud-based telephony. So they've moved away from, I'm sort of exaggerating to make a point, but sort of copper wire coming into the surgery with a set number of phone lines that have to be answered, to a digital platform that allows call stacking. It allows automated callback. In some cases, some of our practices are starting to move towards what's called a total triage system, where everybody who wants to come to a surgery actually gets reviewed by a doctor. Not many in the Maldon district are doing that yet. That's mainly Chelmsford that have piloted that. But what it essentially said is that this cloud-based telephony, and it's a national programme to help fund it and roll it out, is it improves. One of the GP survey questions is, how easy is it to get through to your general practice? And it's one that's been going down in recent years. Practices that move to these cloud-based systems, on average, you can see there it says they improve by 30 percentage points. And what it does is it allows queuing and multiple call stacking. It does callback options, so you can say, I can't hang on now, but I want someone to call me back, and it puts you in the queue. It can do call routing, whereby you can put people to the different ARRS, ARS roles that I referred to earlier, and it also allows digital integration with clinical systems. I'm not suggesting that all the practices in our district have got it right yet, but many of them are now working towards this. And if you look at Blackwater in the last maybe 6 months to a year, where they've really moved towards this, again, I'm not saying that they've got it perfect, but when you speak to patients, and I go along to the Blackwater Patient Participation Group. They recently worked with an organisation called Healthwatch Essex. What they're actually seeing is that they're getting significant improvements and an improved patient satisfaction. Patients are essentially saying it's better than what it was now. And I'm not saying it's perfect, but lots of people saying that it's better than what it was. The problem with the GP national survey, because it's done commissioned nationally, and I think it's like Ipsos Mori or someone who do it via their formal mechanism, it only comes out annually, so it doesn't allow the GPs to sort of see in real time whether the things that they're doing are making a difference. A number of our practices now are using sort of snapshot surveys with their patient participation groups to try and see if the change to cloud-based telephony, among other things, is improving patient satisfaction in their access models. It's difficult to kind of go into the detail on this because it does vary depending on the surgeries, and so some of you will say, well, it's not like that in my surgery, and it might not be, but many surgeries are moving towards this, and they will all in time move towards this type of model. And I guess it is modernising the way in which we access general practice. And the whole national delivery plan, as it says at the top, for recovering access to primary care is in essence to try and move away from what we refer to as the 8 a.m. rush, but you would all recognise what I mean by that. It's trying to get away from this concept that you have to phone at 8 o'clock in the morning to get available appointments. I'll flick that on, because I'll stop there, and at that point I was going to move away from sort of primary care access and onto some of the estates issues, but again, happy to take any questions before I move on.
Okay. No, I think we can move on. Yes, please.
Okay, thank you for that. And as I say, as is often the case, if anyone has a particular query on one of these things and you want to get in touch with me afterwards, please, happy for you to do that. So I'm just going to go over some of the estates projects that we have in the pipeline to make sure that you're all aware of them. At the moment in the town, and many of you know I live about 400 metres away from here and have been in the town for a long time, so I'm well aware of the kind of rumour mill that can circulate as things are at the moment. These are all sort of based on fact as of February, so they give you a true reflection of where we're at. So Blackwater Surgery, you'll know, has been desperate for more space for some time. Thank you to yourselves again, because you've allowed Blackwater to lease administrative space in this building, which they've done so. They migrated a couple of practice administrators over from Blackwater into here some months back. And what they've now done, and again, if you saw the Blackwater patient leaflet that got published recently, they put a photo of it in it. They've now transformed that vacated administrative space into an additional clinical room. Incredibly timely, because they've just recruited a new GP partner, as I said, and they've now got an extra room in order to put that person in. So it's a small win, but for Blackwater, it is significant. It was developed, as it says there, with the use of Section 106 funding. The partners do put some money in themselves, but it's just a good project, and it's one that has given us a little bit more space within Blackwater in the immediate term. Longer term, we need more, but we'll come on to that in a bit. The next one up there is around Longfield, and many of you will know that Longfield have a number of plans and have over time had a number of plans to extend their existing surgery. So again, apologies because I point and I appreciate this is being recorded, but Longfield, obviously the practice just adjacent to us here on the right, if we were walking out the building, the practice is now planning to extend in 2 phases over the next 10 years. When practices and partners extend the building, whilst they can access either money from the NHS or money from Section 106, they also have to put in some money for themselves. And this is to ensure that partners who own their own estate, and in many instances the partners own their own buildings, don't necessarily profit from their subsequent sale of that building when it's been public money that's extended it. So it makes sense when you think about it. So they usually put at least a third of the money in themselves, and that can then be augmented. We sometimes then essentially recoup some of that money through a rent abatement scheme. So in essence, what it ensures is that if partners get bigger, better buildings as a result of public money going in, they can't then subsequently just sort of sell that building for a profit. So just in case you're wondering why it's not 100% funded by the NHS. But the ICB, we're working with Longfield at the moment to make sure that the capacity that they're wanting to put in will give us enough, not only for the here and now, but also for the growth coming into the town. We've obviously got a lot of growth and we've got a number of projects. What we've got to make sure is that when you add all those projects together, they add up to give us sufficient capacity within the town for what we need. They have to do a thing called a PID. Again, apologies for the 3-letter acronym. That's a project initiation document. That then leads on to another 3-letter acronym, an OBC, an outline business case, and then that ultimately goes on to an FBC, another 3-letter acronym, which is a full business case. All of those things as they stand need to be signed off by ourselves, but because of the financial consequences of them, they also go up to NHS England, our regional colleagues, to be approved to make sure that they can go ahead. Once the full business case is approved by ourselves and NHS England, building work commences. So we last met with Longfield at the start of this year. We're basically now just chasing up on Longfield on exactly what their timelines are internally for them in terms of extending that building, but that will give us hopefully a better facility for Longfield. If I move on, because this is a jigsaw and it starts to kind of add up more as you get to different bits of it. So the next one is, it says Heybridge North Surgery. We still refer to it as the Heybridge Garden Suburb or Heybridge North. Obviously the development site itself is now called Westcombe Park. I find when I'm talking to the public and I say Westcombe Park, a lot of people still don't know what I mean. So I just sort of say the development in the north of Heybridge. But in essence, this is a new general practice healthcare facility on the new development site in Westcombe Park. It will replace the 2 branch surgeries for both Blackwater and Longfield Medical Centre. So one of those is at Bentall's, and one of them, it's not Ailing Road, it's one of the near Maldon Primary School in Heybridge is the other one. If anyone remembers the name of the avenue, they'll tell me. Pardon? That's it. Well done. It replaces those 2 branch surgeries, which I guess if any of you know them would know they're not the greatest, and they're not in the greatest condition. Their leases are coming to the end as well. This gives us a very significant facility in the north of our district, the north of our town, and one that I know the people of Heybridge have been campaigning for some time. The plan currently will be for 14 consulting rooms in there, so it's a significant building. I think it's around 800 square metres, I think, from memory, but it's a big space. 6 treatment rooms as well, so it's a sort of 20-roomed clinical room facility. The exact layout we're still finalising between the developers. Obviously it goes into yourselves for pre-app planning and things like that as well. But the PID, the project initiation document, using the previous terminology, has now been signed off by us and has gone to NHS England for approval. There have been a few little delays between some changes that were put in the pre-app to what the GP partners had seen, but I think we're over those now. NHS England came back, as they always do, to us with some questions around value for money and are we getting the best possible layout. We've gone back to answer those and we're just waiting on those the response from NHS England there. Once the PID's approved, same process, outline business case, full business case and sign off. The delivery timeline that's being estimated at the moment is the end of 2025, and then the developers would start work, and they're anticipating it would be a 12-month development build. So they're sort of saying with a fair wind, late 26 is possible. My experience is they often do drag a little bit more than that. So I think that would be optimistic, but it's what they're saying at the present time. But a very, very significant development for our town and for our district. It will serve, obviously, all of the growth towards the north of the patch. The key thing that I stress, though, is exactly how that building is ultimately used will come down to a model that the GPs themselves will develop. And I suppose what I mean by that is many people sort of assume that it will just be another generalist facility. Lots of GP partners, and this is your point about where they collaborate as well, are often now where they've got several sites within close proximity, using different sites for slightly different purposes. So for example, some might use site 1 as their emergency access hub. So if you've got a acute respiratory illness, likelihood of antibiotics, infectious illness, coughs, colds, those sorts of things, it might be go here. If you've got a chronic review for your diabetes or your asthma or your long-term condition, it might be go to this site. I'm not saying that they will do that. Please don't think that I am. All I'm saying is we mustn't just immediately fall into the trap of just assuming it will be a general practice in its own right. It could well be that that's what they say, is it's just a general practice. But between them, they might determine that by doing different things on different sites, they can provide a more efficient service. That will obviously come down the line. What I would certainly be encouraging the practice to do is do that in cooperation and conversation with their populations that they serve, their patient participation groups, etc., etc. But obviously a significant development to be aware of. The Wick Hill development, I know many of you were talking to me about this beforehand. You'll be aware that as a CCG, as we were before we were changed to an ICB recently, we undertook with yourselves an options appraisal of the best sites available to us for a relocation of Blackwater surgery. This was primarily a relocation of Blackwater surgery, but it was also always envisaged that it would give us additional clinical space to relocate outpatient and diagnostic services from St Peter's Hospital. With yourselves, we went through multiple site appraisals. Many members and officers were involved in that, as were the public. Ultimately, we settled on Wick Hill as being the most optimum site for a whole raft of different reasons. Many of you will be aware now, though, that we had a programme business case being developed for Wick Hill. However, that has stalled because of issues with land ownership, with issues around the relief road, and with issues potentially around the development itself not necessarily going ahead. At the moment, we are not assuming that Wick Hill is a viable option in the immediate, medium, or even long term for us at the present time. Many of you will be aware that the leader of Essex County Council has organised a infrastructure summit for Maldon, which I'll be attending on behalf of the NHS this Friday. I believe District Council colleagues are attending as well. Obviously, we'll take part of that. At the moment and at the present time, though, we are looking at alternative solutions for Blackwater surgery and St Peter's, as you would imagine that we would do. But that was the programme business case as it stands, and there was a lot of work that went into that business case. It still sits there. I appreciate people who have some questions on these. I'll just carry on. St Peter's, I guess it's how much do you want me to go into that now? Because I think many of you have heard me speak probably too many times recently. I'm thinking of you, Councillor Driver, you're probably fed up of hearing me talk about it. But many of you will know about that. I can go over that if you want, or I can sort of pause there for questions on the other primary care projects. There's one more though, sorry. So I think if I remember my slides, there should be Burnham and South. It says two more. How could I forget Burnham? Don't tell anyone I forgot Burnham. So Burnham, you'll be aware, obviously there was a lot of, I guess, controversy and interest in Burnham. The surgery have long wanted to relocate. They've felt that, the statistics, the numbers say that they've got less space than what they need for the population that they serve, and their population is growing like everyone else's. So they were looking at mechanisms and opportunities available to them for expanding their space and the available estate that they had. They asked an organisation to undertake an options appraisal for them, and the options appraisal concluded that the best available option for them was to piggyback on the back of a local development and get an entirely new build, developer funded, that they could then move into a brand new build. The development in question was the Burnham Waters development. That obviously then went into the public domain and generated an awful lot of interest. And I've been to Burnham many times in recent weeks and months to talk to the population, and it's abundantly clear that the population are not keen on that move. On the basis of that feedback, we've done a number of things, but primarily we've worked with the owners of the existing surgery, which are two retired partners taking the conversations previously. You can see where sometimes they lead, and the existing partners who are tenants within that building. And at the present time, I guess all I can report on that at the moment is that the existing owners, the owners of the building, are very open to the idea of expanding that building in any way which is, I guess, actually viable. They're prepared to put some of their own resource into that, and obviously they'd welcome that being bolstered and augmented by some of the 106 money available. We've spoken to the partners of the surgery who are acutely aware of the feedback from the town, and equally are committed to exploring the options as to what can possibly be done. So what we're doing at the moment is working with both the partners and the building owners to try and get, I presume it would be a structural engineer and a health planner, to assess the site, to basically tell us what is the art of the possible with the site that's there. What possible scope is there for expanding it either upwards or outwards, or converting different parts of the building, so that we can start to see if there is a mechanism that will release enough capacity to service the needs of the town in a way that keeps the firm locus of Burnham Surgery within the town and gives better facilities to the GPs for what they need. What the GPs have asked us not to rule out is them then potentially taking branch space in one of the developments, including Burnham Waters, because they serve a significant volume of people from outside of Burnham town, including Althorn. They will have to serve the people of Burnham Waters as and when it starts to become populated. So whether they like it or not, they are going to have to pick up that population. But what they are saying is that they'd like to consider maybe taking a couple of clinical rooms so that they can base a doctor out there to stop people travelling in, which in itself obviously then frees up more of the space in Burnham Surgery for the people that come from Burnham town. I've spoken to members of the town council, I've spoken to obviously all the partners and the owners, and I've spoken to the PPG and members of the, I believe they're called Save Our Surgery campaign group there. And generally speaking, I think people have welcomed this as an approach and feel that it's a pragmatic way forward. I don't have anything more concrete than that at the moment, because these are conversations that have genuinely taken place within the last 2 or 3 weeks. So the next step obviously is to get people who know what they're doing to look at the building and see what is actually viable within that building. I think that has covered that one. William Fisher, or Southminster, for those of you that don't know it as William Fisher. This was a scheme very similar to the Burnham one, actually, where they want a new surgery. They're under space according to the amount of patients that they need, and so they were looking to get a new surgery, again piggybacking off the back of a development in the town. And for those of you that don't know, what happens here is a developer who obviously will be building a number of houses in an area will offer to fund the capital investment to build a GP surgery, and that can be anywhere from say £3 to £5 million. They put that money in up front, and then in essence they recoup that over a period of a lease with the NHS, which is usually say 20, 25, 30 years, and the NHS will lease that building back, and obviously the developer makes back their money, plus they make a profit margin on it, which is why they do it. The issue that we have at the moment in Southminster, there was, many of you might be aware there was a time issue around the land, and the assurer, who's the developer in this question, is the partner that the developer's using for the health aspect, exercised the option to buy the land, so that they've bought the land on the basis that this can go ahead. So that took away that initial time constraint that there was. But the issue that we face at the moment is that lease arrangement that I was explaining to you. The NHS just can't pay whatever it likes. It has a rate dictated to it by a person called the district valuer, who works for the planning authority, yourself, who says this is an appropriate level of rent for this type of building in this type of vicinity. And the reason is twofold. First of all, it kind of ensures that the rental market doesn't go out of hand and become overly inflated across the board. But I guess more significantly, ensures that the NHS is getting good value for the taxpayer, because what the NHS can't do is just pay, endless amounts of taxpayers' money. And some of you will remember PFIs, which are fundamentally a bigger form of this. The NHS has often found itself hamstrung by paying inordinate amounts for a building because that was the only way it could get the capital. So the issue we have at the moment is that the rate that the district valuer is advising the ICB is an appropriate rate is significantly out with the rate that the developer would need in order to make the scheme profitable. So what the developer has agreed to do is three things: is undertake what they're calling a value engineering exercise, which is basically to ensure the specification of the building is as basic as it needs to be, and the materials that are being specified are the most economical that they could buy. There won't be any architectural flourishes within it. It will be what it needs to be. They'll also go out to tender for a contractor, because what they're basing their initial figures on are estimates, and obviously estimates are estimates, but when you actually go out and ask contractors what it would cost to build the thing, you can get a more concrete thing. And then they're engineering all of those figures into different commercial deals with the NHS over 20, 25 and 30 years to see if they can close that gap and make it a viable project. They've suggested to us that would take them probably until the back end of summer to do all of those things, at which point they'll be presenting a conversation with us that says they've narrowed the gap and made it viable, or perhaps they haven't. Many of our local politicians, MPs, and up and down the country are highlighting the fact that the gap between the district valuer's rate that is imposed for the NHS versus the rates that contractors, the developers are now looking for, the gap is getting wider. One of the main reasons is the increase in global construction costs and the DV rate not keeping up. That's way beyond my pay grade, and that's something that nationally they're talking about. If something changes nationally, that may allow that to happen. Otherwise, we can only work with the developer as things stand and try and do what we can to bring that gap down. Having said that was it, I forgot those two, so apologies. I think that probably is enough on that at this point, and I'll take any questions on any of those. Sorry, that was a bit long-winded, but it covers, I think, all of them.
No, thank you very much indeed, Dan. That's very, very informative indeed. You were saying about the meeting on the 8th of March that more district councillors know about it. Well, this one certainly doesn't. I don't know if anybody else does. No, interesting. Okay, Councillor Spencer. Yeah.
Thanks, thank you. So I apologise for having sort of clumsily looked at those GP ratios a while back, but the reason that I was sort of mumbling on about what they actually were and what they were 10 years ago is I'm just curious, because it's absolutely fantastic, this. You've presented us with all this information about how things have moved on, and I do appreciate all the work that you've put into that, Dan, because it's very informative for everybody here. However, I do have a question with regard to St Peter's. It won't surprise you to know. And see, I did a little bit of research, and I looked for some minutes, and I've got those in front of me here. Actually, it's from the Community Services Committee of 30th of March 2010, and it's great because it talks about a lot of what you're talking about here. I mean, we've got here something about the Strategic Services Development Plan, which obviously was considered to be a very important thing back in 2010, if you can bear with me. And that's why I was asking, had there been some massive change in our, the way that our primary care functions here, had there been significant improvements in the last 10 years, because looking at those ratios, I suspect that there hasn't been. And there was a proposed model not only of having the primary care centre in Heybridge, which was something that was expected in it back then, and new surgeries in Burnham on Crouch and Danbury and Southwood and Ferrers, and they were all supposed to, I'll read you this paragraph, just sorry folks to bore you. Informal consultation on a Strategic Services Development Plan, SSDP, was undertaken by the then PCT in March 2005. This set out a proposed model of a community resource centre, i.e. a hospital, in Maldon, with extended primary care centres in Danbury, Southwood and Ferrers, Mayland, Tollesbury, Tillingham, Southminster and Burnham on Crouch. In addition, there was a proposal for a new primary care centre in Heybridge. It all sounds wonderful. The thing that's missing, of course, is the hospital. And I'm just wondering what it is that's changed since then that has somehow led the ICB to conclude that we don't need that now. What's improved in all that time for us to not need that now? Is that a simplistic question? Because I don't know the answer to it. And all these figures are great, but they kind of don't give me that answer. And I know at the beginning you said to me that you promised, or that the ICB is promising, and I know that Tracy Dowling actually said it to me when I went up to her after the public meeting on the 9th of February now, that, this is trouble, my head's so full of facts and figures, I'm kind of dying underneath them, but anyway, that actually all the services would be kept here, although I'm really deeply concerned by that, because there was no one there from the Foundation Trust, and that's, of course, who owns the hospital. So I wasn't sure how Tracy, with all due respect, could be promising that, because we don't know where the money is going to go from the hospital. And then there was this awfully confusing thing about, well, we couldn't provide any other services or make any other investment until the money from the hospital had been realised. So then I was very curious as to where everything was going in the interim, because it seems to me like there's been an awfully long time to make a plan. And now we've got some sort of knee-jerk thing going on. And actually, none of the members here know what the plan is here with regard to what's going to happen, do we? Whether what we're going to lose, what we're going to keep, where the services are going to be, how many porter cabins will be in the car park, I don't know. And I'm sure I'm probably not supposed to say all that, but actually what I'm left with is a deep sense of despair for the residents of Maldon. This is no political speech, by the way, this is just how I feel. And I don't know if anyone else in the room feels like that. But I just would love to know what this consultation maybe is missing is why this, the questions maybe should go the other way. Why is it no longer needed? And that's the thing that's puzzling me perhaps most of all. I'm also deeply worried, and I'm quickly going to say this about the consultation, because I don't see how any of us can answer the last question, the last section in it, because there are no firm proposals. And my fear is, how even are you going to interpret that? Because you've got this thing from very bad idea or whatever it is to great idea. But the question is, we're going to close a hospital and put services in or around Maldon. So everyone says that's a very bad idea. How do you actually interpret that into anything logical? I think that's a mark of the fact that this plan hasn't been thought out. And what I'm going to say now is I hope that in future meetings here, what we get to find or what we get to see is a really clear, firm plan, a worked up proposal, a firm plan for what's going to happen in the short term and in the long term. And without that, great though all this is, I don't really, I have to say, feel that I've got any real faith in the health provision here. And I just hope that when we see you again, Dan, or somebody else here, and I hope that you carry on coming, because I feel that maybe these conversations have been lacking for too long, looking at this, much too long. And I think it would be really, they obviously did used to happen, by the way, but they haven't happened, I suspect, for a long time. And I hope that that carries on and that you'll be able to come here and update us with what those plans are. Thank you.
Well,
Over to you.
I'm not
Dan.
entirely certain exactly how many questions there were in that, but I guess what's changed would take a long time because a lot has changed. But also, you're absolutely correct in that a lot hasn't. So, out of interest, all of the primary care sites that you named from that document that I think you said was 2010 do still exist, and in some cases, several of them have improved and have developed in that time. Thank you. I was probably there, Paula, actually. So I'm just going to see whether I was in attendance. Maybe I wasn't, but I suppose the point being is, you referenced a new facility in Southwood and Ferrers. I appreciate you saying to me it's not in the Maldon district. That happened. The new facility in Danbury happened. I've updated you this evening on the new facility in Heybridge, and my hope is that happens exactly as I've said. Likewise, I've expressed the challenge that we faced in both Burnham, where a new facility potentially was a possibility. Obviously, it wasn't necessarily what the townsfolk wanted. We're trying to adapt and accommodate to that. And likewise, the challenge that we face in Southminster. Equally, Paul, I apologise that fills you with despair because, I guess we are endeavouring to do everything that we can. I think one of the most significant changes that's occurred since 2010, and I say this as much as a clinician, as a physiotherapist, as opposed to an NHS director, is that there's been a significant move to home-based care and rehabilitation. It's a change that we've started to see in a number of areas of rehab, and that has led to lots of areas looking at their bed configurations and bed-based. That said, Tracy Dowling said publicly at the meeting in Maldon that we need the services that are the ambulatory services that St Peter's provide to remain in the district, and that's something that we're endeavouring to do. I appreciate we don't have an absolute concrete answer that we can give on exactly where those services are at the moment, but I can assure you that we're endeavouring to do everything that we can to get to a point where we do have a concrete answer. What we've also said is that those services won't disappear from St Peter's until we've got somewhere safe and effective to relocate them to. So at the present time, they'll remain in St Peter's until we have somewhere to relocate them to. So the ambulatory services, the blood testing, and I appreciate ultimately people may not believe me, and that's people's own choice, but things like blood testing and things like outpatient services will remain at St Peter's until we've found somewhere to relocate them to. Do we want to relocate them? Yes, we want to put our staff and the staff that serve our public into a better facility to be able to serve this district, and that's what we're working towards at the present time. Equally, and the consultation doesn't reference primary care, but my job is to keep working towards a better facility in Southminster, a better facility in Burnham, and to find a better facility for colleagues over the road in Blackwater, and equally to do what I can to support Longfield in expanding their facility as well. That need is recognised by the NHS and something that we're working towards. So I guess that's it probably doesn't answer all of your questions, Paul. I'm sure it doesn't, and I'm sure it doesn't necessarily address all of your despair or anxiety that you've expressed. But what I can say is that we are endeavouring to do everything within our power to try and find solutions to many of those things. But there are many challenges that we face. There were going to be some other questions, but I kind of
thank you, Dan. For a bit of information on my personal Ouija board, I've now understand that the meeting on Friday is a closed meeting, which is probably why we haven't actually heard about it. So,
Can I just come back very quickly?
Yes.
I just wanted to say, Dan, though, you will be coming back with a firm plan, I hope.
Whether it's me or somebody else, I'm sure somebody will come back with a plan.
We need firm plans.
Yeah, and I know that one of the things that's been suggested is that if we are able to announce what our plans are for the relocation of services, that might result in the extension of the consultation as well, because people would want to then have a comment on what that is. So that is something that people are aware of. And equally, it was interesting because when I spoke to the chap here, he said, "Did I know where the chamber was? Was it my first visit?" I said, "No, I've been here many, many times." and to all of you as councillors, hopefully you know by now, I will very happily come back to this committee at any point that you want to update on any aspects of local NHS care. Equally, I'll come to your relevant, those of you that are parish or town councillors, I'm very happy coming to talk to you at a local level or any group there as well. So I certainly won't shy away from the conversation.
So, Councillor Sildorn, did you have a...
Yes, I was here on this council when that report was made. The thing is this, I feel personally that we still need a hospital, obviously. Are we prepared, all of us, all the people the people that are filling this form in, are they going to be listened to? Are we prepared to put the amount of work in fact, that the people in Burnham did on their surgery? Because I believe that's what's needed. Because, to be honest with you, we need a hospital, but it's very difficult. You're just the... I understand that you're just a messenger.
No, I get that, that's fine.
However, the problem is this. First of all, we've got to decide, if you were going to have a hospital, it's got to be in the middle. It's very difficult. How... Oh, I mean, I know that you're not in a position to give us that advice, but how is this council going to make it aware that the people of this district do want a hospital, as they did the surgery? So we need the way forward to make sure that that happens. Again, it's the third time that I've talked about it in this council, and it's really worrying me that are we ever going to do and what we know we need? Because for a start, we've been told the problems we have here: transport, no doctors, teachers, no. All those things relate to what we're talking about with this hospital. We, the people of this district, are all over a barrel because we can't change what's happening unless we all decide that we're not going to accept anything different. Thank you.
I understand what you're saying, and the one thing that I can say, I mean, some of that I guess wasn't necessarily directed at me. The two things that I can say, the first thing is, and I can say this from my perspective, is that the support and engagement that we've had from the district council, both the officers but also yourselves as elected members, has been, fantastic, and it has helped enormously. So that is something that has happened. So the second thing is, contextually, the response to this consultation has been absolutely enormous to date. For context, back in 2017-18, just before the pandemic, some of you may remember, we did a consultation over some changes of acute hospital services, cancer services, those sorts of things. Similar process to what we're going through now. We had about 400 responses from the public and stakeholders. We're about to tip over 3,000 for this consultation, of which it wouldn't surprise you to see that the lion's share of those, the vast majority of those, come from the Maldon district. Obviously, I was in town at the weekend, saw the gazebo by the War Memorial. I've seen the flyers that are up all over the town. One of your questions was, are the town going to sort of stand up and be heard? From what I can see, the town are responding. We've got the event, and now you're going to get me without opening my computer, the event at the town hall that's coming up on the 19th. Thank you, Paula. That's a specific event to this town. There is an event in Burnham tomorrow afternoon and evening. I've had the invitations to the public meeting here. I've had Councillor Stevens hold a meeting that was well attended in Tollsbury. I don't think just the town, I think the district is certainly ensuring that its voice is heard. Certainly all of those responses will be analysed. It's an independent organisation that then analyses those, and we will be held to account to demonstrate that we've taken those into account. I should just say there, Councillor, I'm just appreciating that this is a formal meeting. When it then comes to the decision, I actually won't be involved in the decision because I do have a conflict of interest because I've worked at the hospital for over 15 years myself, and my wife is currently a practitioner in the stroke service that is ultimately affected by this consultation. So whilst I'm happy commenting about it, I won't actually be involved in the decision. I just thought that, given you asked that at the beginning, I probably should have said it then. But
Councillor Stevens.
Thank you. I've got a couple of questions and then a follow-on, please. So first of all, I'd like to know if paper surveys have been provided into GP surgeries, because so many patients just don't do online, and I'm providing some paper surveys in the village. So I'd like to know if all GP surgeries have got a stack of paper surveys for their patients, please. I'd like to understand a bit more about the 19th of March, because as I understand it at the moment, it's for members of the public and groups and organisations to give evidence. And I'm very confused about what evidence I might have. I mean, I can come along with bus timetables and prices of how much it'll cost somebody to get from Tollesbury to Brentwood or something like that. But the clinical evidence is surely within the NHS's area to provide. And my third question, which will lead on to something else, did St Peter's used to have general rehab as opposed to just stroke rehab beds, please? Thank you.
I'll try my best to answer those. So did St Peter's have general rehab? Historically, yes, it definitely did. Certainly when I started working there, again, apologies to the recording because this won't make any sense, but the left-hand wing was general and the right-hand wing was stroke historically. I couldn't tell you without checking, Councillor Stevens, the exact date that changed, but there was a time that was the case. The question about the 19th, and this is my understanding, but I will double check it all with the team, is that it does give people the opportunity to present, I guess the terms used is evidence, but I guess it's their case, and it will be a specific opportunity to speak to clinical experts. I know that a number of clinicians are intending to come to challenge some of the evidence that's been presented. I know that people are going to present things like, you say, travel times. They're going to present data on numbers of particular cases around different things, and it's essentially people's opportunity, I suppose, for more dedicated one-to-one time to be able to, I suppose, almost get into a kind of debate with some of the decision makers around some of the more specifics of elements of it. Some of the things that you said you might bring, I think, are perfectly sensible and relevant things to bring along, but I know other people have got a lot of historic data. Some people are bringing, I was going to use the term stuff, sorry, that's a terrible term to use in a public meeting, but information about the conservation status, the history of the building, all sorts of things that people are putting together. So I'll double check it, but I think it really is open to individuals to be able to bring what they think. And apologies, Councillor Stevens, remind me of the first question again. I've lost.
It's fine. I was interested to know whether paper surveys have been provided to GP surgeries, please.
I genuinely don't know that, so I'll have to take that one away. I genuinely don't know. I think they certainly have been to some. Whether that's universal across the board, I don't know. And I suppose if I'm being honest, there are parts of Mid and South Essex where quite clearly the general response from the public on this has been virtually zero. There's no interest at all. I think probably you're suggesting it would be far more pertinent for the Maldon district, and I'll take that away. I don't know whether they have been or not, but I'll find out. I wouldn't want to answer.
Thank you. And so then if I can come back, so I thought that there had been general rehab beds at St Peter's. And there's the answer. That's why people don't trust what's going on, because they were slithered away, as far as I'm aware, without any consultation. The birthing unit has already closed and the stroke rehab has already moved. So people are hearing this promise of, oh, no more services will go, or at least the outpatient services won't go. But these others have already been sort of slithered away before the consultation even started, and there hasn't been a consultation about the rehab beds at St Peter's as far as I know. That's why people are not really believing what they're being told, I've got to say. Thank you.
I guess there's no necessarily any reason for me to respond to that. I completely understand what you're saying. The only thing I'd reiterate is that the beds were moved in October. As you said, the stroke beds were moved, and the midwifery unit was moved then, and that was done as an interim measure for the winter under the fact that we felt it provided safer services for the public, knowing that there would be this consultation. But what you said is correct, so I do understand your point of view, Councillor Stevens.
Thanks, Dan. Well, I'm going to make a nuisance of myself yet again on the ratios, but it's not from me. It's from another councillor who sent something in to me, which I've been monitoring. And you can take this away. You don't have to answer this one now. So the first point I have here is, it says if there are everyone will guess who this has come from. If there are 47.93 FTE GPs, the ratio would not be 2,500. It would mean there are 27. So I'm going to send that on to you because you're probably not going to be able to work that out just now.
27 GPs?
Yes, if the ratio, it's saying if there were 47.93 full-time GPs, the ratio would not be 1 to 2,500. It would mean that there were 27
GPs.
Yeah.
Yeah, I suspect that please do send it on.
Yeah,
but
it's a genuine query.
Yeah, my sense is that the data that I provided to you up there wasn't practice specific. It was what we call PCN specific, primary care networks. As I said to you earlier, a number of Maldon practices are in networks with other districts. So, for example, Tollesbury, I'm looking at you, Councillor Stevens, are in a network with Blackwater, but also Whittam practices, and a number of the Dengie practices are in a network with practices in South Woodham Ferrers, and you saw that I named several South Woodham practices in that data as well. So I suspect that councillor has looked at the district population and done the calculation, whereas what our data will be a bigger catchment than the district. But I will, if you forward that on to me, I'll happily look into it statistically and make sure it's accurate.
Thank you. I've already forwarded that on to you, Dan, very quickly, because it's obviously somebody's watching the meeting.
That's very efficient of you.
Yeah, one very quick question further of myself, only because I know that this has been, and I spoke to you about it before the meeting, so I think it might be worthwhile for the tape giving this one. There was some discussion around the Brentwood bed. So very quickly, without explaining it all, it's something that came up over the Brentwood meeting that's been communicated with Maldon residents, particularly those in the campaign group. And I was asked this question. So with regard to the stroke beds moving to Brentwood Community Hospital, can you confirm whether these would be prioritised for Brentwood patients or not, whether they'd be prioritised on clinical need rather than people living in Brentwood? Thank you.
So I'll certainly check what was said at the Brentwood consultation meeting, but my understanding is that always beds will be prioritised on clinical need. If there are different options in the consultation, and one of those options, as many of you will be aware, that all of our stroke beds are concentrated at Brentwood. If that was the case, it would simply be on clinical need. One of the options, however, has stroke beds split in a north and south split. So there are, I believe off the top of my head, 25 at Brentwood, and then there are some at a unit called the Cumberledge Intermediate Care Centre, which I believe is in Rochford. If that was the case, I would check. I will still double check with the clinical teams, but I would certainly hypothesise that in that case they would try wherever possible and where it were clinically appropriate to do so, to bias the Brentwood beds towards people coming from the north of the patch, so the Broomfield catchment, and the Cumberledge Centre in Rochford towards people coming from the South End patch. But where even that is the case now, whilst clinical staff will always try, if possible, to place somebody into an intermediate care or stroke bed that is within their catchment, if there isn't a bed available and there is one further away, obviously people go to where need is based on clinical need. But I wasn't present at the Brentwood meeting. I've generally had my hands full with the ones in my own patch, if I'm being honest. So I will double check with colleagues who were there to find out what was said, Councillor Spencer, and let you know.
Thank you.
Right, any further questions for Mr. Doherty? Dan, can I? Oh, wait, sorry, John.
Almost.
I'm afraid, Dan, this is not a question. It's an observation. And I know that in one sense there's nothing you can do personally about this, but I was a member of the Longfield Patient Participation Group in 2017, and what was presented at that meeting was the Heybridge Medical Centre, a replacement to the Blackwater with an additional medical hub, and that was 2017. And we're now 7 years on, and we've moved backwards from that. Actually, we are now in a position where the Heybridge hub or medical centre looks like it's a runner, but in terms of other provision, we've gone backwards from a position where it looked like it was going to happen to one where it's looking decidedly problematic. So I think people's frustration, you know, as you've heard and you will be hearing lots of times, is when people are told things and then years pass and nothing happens. And in fact, more than that, we appear to go backwards. It makes it very difficult. So I know you can't actually respond to that in one sense, other than it's going to be really important for the NHS to look at how it moves forward and provides provision that meets the needs of the people of the Maldon district, because it's needed. I know you know it's needed, but actually I think, you know, people want to see action on the ground and something happening. Thank you.
I guess I can respond to it and say, I do 100% understand your frustration. You know, I guess from my perspective, it's just to keep on pushing on all of those projects, and I do appreciate that it feels like maybe one step forward, two steps back. Certainly when, in terms of that Heybridge one though, and I appreciate you referenced 2017. Obviously, we were fairly busy between 2017 now, but if we can move that forward, for me, that is a massive win for this district. It's a big win for Heybridge. It will give a fantastic facility for a growing population. You know, I appreciate we've got the questions around St Peter's and the questions around Blackwater, but certainly I suppose from my perspective, where there are opportunities and they seem to be open to us at the moment, then it's my job to try and capitalise them on them as best as they can. That's something that I can just assure you that I'll continue to do so, and equally, if I need the support of yourselves, I'll be coming to you asking for that support. I mean, beyond that though, you're right, there's no, I mean, I do understand exactly where you're coming from, and I do appreciate all of you that have put the time into things like PPGs and things like that. I appreciate there's a frustration sometimes when you think they don't achieve anything, but they do achieve things, and there is a lot of good that's come out of the PPGs and other forms of kind of patient forums and things. So I do continue to attend my local one at Blackwater as well. So I'd encourage any of you to do that, or encourage constituents to do it, because they are really valuable. I don't think there's anything more I can say on that particular one.
Thompson?
Thank you. You'll be pleased to hear. It's actually not a question. I just want to say thank you. I don't normally sit on this committee, so I found this particularly interesting. I'm sure we all have. Really appreciate the work you've put into it. And I know we're not hearing what we necessarily want to hear, but we appreciate all the effort you put into it. So, Mr. Doherty,
I appreciate that.
Thank you.
Thank you.
Yeah, I would reiterate that, Dan. Thank you very much indeed for coming and addressing us with a very informative brief, and that really is appreciated. And I also appreciate the fact that you're prepared to come back with your colleagues, and I'm afraid we're going to probably take you up on that.
It's not a problem at all. It's fine.
I would also say thank you for all you do in the health service, because you're obviously a health service professional as well. So we do all appreciate it. Isn't all your fault, but obviously unfortunately you're here to listen to us. So thank you.
Completely understand. You've got jobs to do as well, so I fully understand where you're coming from. So it's not a problem coming at all.
Thank you so much for what you've done for Burnham. Much appreciated.
Thanks very much. I'll let you move on, and we will move on ourselves. Right, while we rearrange the screens. Thanks very much. Oops, try not to injure yourself going out. Right, okay, moving on then to agenda item 7, the scrutiny work plan item, planning decision making, which can be found on pages 11 to 16. Mr. Jennings, is this anything you want to address us on specifically at this stage, or?
Not very much, Chairman, because this has been back and forth to your committee on a number of occasions now, and your committee and its working group have been looking at this for just over a year. Just to put it in context, I think as we all reminded ourselves at the last meeting, this scrutiny item does stem from an individual member scrutiny request, together with also a reference from council to look at more robust ways of decision making and controls over decision making. So this is something that the committee has taken on, and I think you are now close to a conclusion which you are able to recommend on to council, but because what is coming out of this has constitutional implications, it needs to go via the Performance, Governance and Audit Committee first. The only other thing I would add is that it came to your last committee, but you did defer consideration, took it back to the working group, and in paragraph 327, there in the bullet points there, that is a summary of the added clarification that the working group was able to give this matter, and this is all commended to your committee now for endorsement and onward transmission. Yeah.
Thank you very much, Mr. Jennings. Has anyone any comment wish to add at this stage? No. In which case, members, we have a... Oh, I do apologise.
That's what I was trying to do.
Oh, dear, dear. Keep swapping glasses over.
Wrong
Councillor
specs,
Thompson,
Chairman,
please,
wrong
yes.
specs.
Yep.
I appreciate I don't normally sit on this committee and therefore I'm not a member of the working group, but I actually feel very strongly that this break should apply for an overturn of an officer's recommendation in both directions, and I will be stating that all over again at the PG&A meeting when it comes forward. But
good luck with that,
just because
Thompson.
it doesn't result in lost appeals and costs doesn't make it a good idea on as many occasions as it actually happens, which is, I find, an alarming number of times. Thank you.
Councillor Flynn?
I was just going to say, actually, I mean, I've had another member sort of looking at this who's emailed me and suggested to me that, you know, there should maybe be an intermediate stage to the break. So there are lots of different suggestions. I now think it's appropriate for this to go to PG&A because it can be looked at there. The constitutional implications can be looked at there. I think as a scrutiny committee, we've probably spent as much time on it. We've got lots of other things that we should be busy scrutinising. So I think I'm just about to put another scrutiny request in myself, actually. So you know, I think moving on now and sending that to PG&A is probably the sensible thing to do. Thank you.
Right, members, we have a recommendation that the committee endorses the proposal for a constitutional intervention or break by way of a deferment, and also for technical briefings, presentations, both as set out in the report for reference to the Council via the Performance, Governance and Audit Committee to enable consideration of the constitutional implications. That I so move. Do I have a second, Councillor Stevens? Is that approved? All good? Thanks. Right. So moving on, agenda item 8, scrutiny work plan item, safeguarding of children and vulnerable adults, corporal risk update, a verbal report. Is this you again, Mr. Jennings, or is that?
Well, Chair, the agenda item says it all, really.
Yeah.
It's just picking this item up as a matter of process, given the detailed report and assurance received by the committee at its last meeting. but without a conclusion really. So I think it would be helpful to know that in the light of the information and assurance received at the last meeting, whether the committee wishes to keep this on the scrutiny work plan, or it can now be kept on a watching brief by the working group, and if the latter, then on what sort of timescale?
Thank you. Okay, so again, the recommendation is to consider whether, in the light of the report to the last meeting, which was accepted and noted, this item can now be removed from the committee's scrutiny work plan and be kept on a watching brief by the working group. I so move. Anyone? Can I have a seconder? Is that agreed, members? Agreed. Good. Moving on, agenda item 9, annual report of the Overview and Scrutiny Committee, which can be found on pages 17 to 22. Again, we have a recommendation to the Council. The annual report of the Overview and Scrutiny Committee for the 2023-2024 is accepted. Again, I so move. Do I have a seconder? Councillor Morley. Again, is that approved? Approved. Great, good. Okay, in which... sorry, apologies.
Just before you leave that item,
yep.
It is worth bringing to the attention of your committee the last two items, and obviously this will be updated in the light of this meeting in onward transmission to the council, but the last two items on Appendix 1, which the working group are dealing with, for the benefit of this committee, involve two further member scrutiny requests that have not to date been formally reported to your committee to be added to the scrutiny work plan. So, in the first item, the corporate project land acquisition at Haybridge, the working group has had a couple of looks at that now and has asked for further detailed information to get a greater understanding of the nature of the issues raised. And in the second item, the housing matter raised by Councillor Stevens, a detailed response was received by the working group at the last meeting, but the working group wishes to go over some of the responses with officers at the next meeting. So I think it's important for the committee to at least acknowledge that there are these two member scrutiny requests in the pipeline, as it were, still to formally come to your committee to be added to the scrutiny work plan or otherwise, depending on the level reached.
Thank you, Mr. Jennings, for bringing that to the committee's attention. So, moving on to agenda item 10, any other items of business that the chairperson of the committee decides are urgent? I have none. Therefore, I declare this meeting closed at 21:21.